Thank you all for coming tonight. Next week, Marcus Vinge from the USDA Agriculture Research Service, Cereal Crops Research Unit, which back when I came here was first called the Barley and Malt Lab, is going to talk with us about malting barley research. So I'm going to look forward to that. And then on January 25th, I'll be here talking about the Venous paradox and the futures of science outreach. Yay. I know, gripping. You probably want to do some push-ups getting ready for that one. All right. Oh, I got to stand here in this little mark here. Where are you standing is great.
All right, all right.
And then can you turn that one off?
I turned it off.
Okay. Thank you. Because I was here in the back.
Mm-hmm.
Welcome everyone to Wednesday Night at the Lab. I'm Tom Zinnan. I work here at the UW-Madison Biotechnology Center. I also work for the Division of Extension Wisconsin 4-H. And on behalf of those folks and our other co-organizers, PBS Wisconsin. Wow, we're going to have to start over.
There's an echo in here.
And then on January 25th, I'll be here talking about the Venous paradox and the futures of science outreach. Yay. I know, gripping. Every week I figure out another way to screw it up.
You're doing great, you're doing great.
Oh, I do a great job of screwing up. I've had hardware stores call me for more screw-ups. All right, we'll start over again. Welcome everyone to Wednesday Night at the Lab. I'm Tom Zinnan. I work here at the UW-Madison Biotechnology Center. I also work for the Division of Extension Wisconsin 4-H. And on behalf of those folks and other co-organizers, PBS Wisconsin, the Wisconsin Alumni Association, and the UW-Madison Science Alliance, thanks again for coming to Wednesday Night at the Lab. We do this every Wednesday night, 50 times a year. Tonight, it's my pleasure to introduce to you Carrie Schroeder. She's with the Department of Surgical Sciences in the School of Veterinary Medicine, and she has been here since 4:30, which...
No, not that early.
All right, 4:45. I really like when the speakers arrive that early because...
I got here nice and early.
I know, I appreciate that. So now I'm going to ask you 5 questions that I ask everybody. You can answer them in any way that you would like. The answers don't have to be true, they just have to be believable. Carrie, where were you born?
I was born in Milwaukee.
And where'd you go to high school?
I went to Brookfield Central.
And where'd you go for your undergrad and what did you study?
Right here, I studied biology.
Study of bio, that's good.
Yeah.
Yep, there's a duct. And then where'd you go for your advanced degrees?
I went to vet school here. I am very Wisconsin, very homegrown.
Yes, that is fantastic. And then how long have you been working for the School of Veterinary Medicine?
Let me think about that. That one's a little bit trickier, so you're kind of blowing the punchline on my next slide, but that's okay. So I graduated vet school here in 2006.
Okay.
I then started residency in 2008 and stayed on till I finished residency in 2011. From there, I never really left. I mean, I kind of moved to Madison thinking that someday I'd go back to Milwaukee, never went and just never left Madison. I took some time to practice very lightly to raise my kids. I've got 3 daughters. And so I came on as faculty in 2020. I was a clinical instructor before then.
Excellent. Mm-hmm. Oh, congratulations. Tonight you're going to talk with us about veterinary anesthesiology, One Health, and all species. Would you please join me in welcoming Carrie Schroeder to Wednesday Night at the Lab?
Thank you so much. Thank you so much. Well, thank you guys so much for having me. This really is an honor to be here. To be perfectly honest, I didn't know about this before, but now I'm learning a little bit more about this. I'm so honored to be here. As I said, I'm very, very Wisconsin homegrown, so I've got nothing but UW pride. So who am I? I'm an anesthesiologist here on campus. I'm, like I said, homegrown Wisconsin, came here for undergrad in 1998 and just never really left. I got boarded in veterinary anesthesia, so I'm called a diplomate of the American College of Veterinary Anesthesia and Analgesia. I got my board certification in 2011. Stayed on with UW, kind of dabbling with some local work here and there, became clinical instructor, and then officially got a faculty position as clinical assistant professor of anesthesia in 2020, just right during the pandemic. I was virtually interviewed here at the University School of Veterinary Medicine. Feel free to email me at any time if you have any questions. I'm more than happy to answer them. I love what I do and I'm happy to talk about it. I got hooked up with this by my good friend Lindsay Snyder, who talked about veterinary acupuncture. That was us last spring anesthetizing a giraffe out in Lake Geneva. So I work for UW Veterinary Care. We have the University of Wisconsin, of course, vet school, where we teach students, perform research, things like that. But then we say it's downstairs. On the first floor of the vet school building, soon to be the new building as well, we have UW Veterinary Care. We provide 24/7 emergency services. As a matter of fact, as I was sitting here waiting to start, my resident called me that there's a dog who got a dehiscence, meaning that the sutures that were holding the abdomen in place had come loose. So I've got a surgery going as we speak, but she'll call Lindsay during this, so don't worry about that. Not only do we provide emergency services, we provide support services, anesthesia, diagnostic imaging, clinical pathology, things like that. And then we have our specialty services, derm, cardio, dentistry, you name it. Pretty much everything you can imagine we have at UW Veterinary Care. So why did I go into anesthesia? When I was a kid, I said I wanted to major in veterinary medicine and minor in paleontology. When I saw Jurassic Park, it blew my mind. I wanted to be the person to take care of the dinosaur, and then reality hit in. I was sadly in middle school, so I was definitely old enough to know better. But then as reality set in, I thought I really, really wanted to do zoo med. I was very, very hardcore zoo med. And then I had my anesthesia rotation, and I realized, ooh, I really, really like this. You get to do all these great things, but it's just this little satisfying case that you can wake them up, walk away, check on them later. You're not just walking away, but it's a very, very satisfying procedure. And we get to work on wonderful, wonderful animals here. We are very, very blessed at UW to have our zoo med outreach and special species team, plus the local Henry Vilas Zoo, plus local-ish Milwaukee Zoo. So I get to work on just a huge variety of species, large, small, you name it. So I'm very, very lucky and very happy and proud to be an anesthesiologist. Okay, MD/DO anesthesiologist versus DVM anesthesiologist. You'll see that there are a lot of similarities, okay? We both go to medical school, veterinary school, and then after that, you need about 4 years of postgraduate training. So on the human side, they do a 1-year internship. On the veterinary side, you either can do a 1-year internship or just practice equivalent, so you're out in practice, and then it's a 3-year residency. And we'll show you later how that kind of comes into play with the One Health doctrine. Okay, so us versus human anesthesia, I always say jack of all trades, master of not really that many, but we do a pretty good job. So we see a wide, wide, wide diversity. There are over 6,000 mammal species. There are over 10,000 bird species, 10,000 reptile species. We see a huge variety of sizes, huge variety of anatomy, physiology, just the way the animals behave. Not only that, but the way the drugs behave with the animal. Oftentimes, we're presented with a species or a case that we don't know, and there's not great literature, so we have to go back to related animals with published data. For instance, if we have a red-footed tortoise coming by, maybe we don't know if this drug works on that tortoise, but we know it works in yellowfoots, or we know it works in a desert tortoise. If we have a camel, well, maybe we don't know how it works in a camel, but we know how it works in an alpaca or a llama. So we have to take some leaps of faith as far as, not necessarily the scientific process, but what we know from anatomy, physiology, pharmacology in related species, and then take it a little step further and anesthetize that animal. Okay, so, I talk a lot about anesthesia to veterinary students, to people like that. This is kind of a wonderful challenge to talk about this with you. So I thought what I would do is just basically, rather than getting into too much of the nitty-gritty granular aspects of anesthesia, I thought I'd basically invite you into what the process is of how we anesthetize an animal. So we kind of look at it as 4 different steps. We look at pre-medication, induction, maintenance, and recovery. So let's take that step by step. Okay, so pre-medication, you may call it just sedation. It's kind of this catch-all term. So it's often necessary for just working with patients. So best case, we have an animal who's just kind of bouncy, just happy, healthy puppy that just is really wiggly. Worst case, we have an animal that's dangerous, so we can have police dogs, we can have zoo animals, we can have anything in the gamut of species and patients. There are a couple ways that we can make these patients more placid and workable. We can give them oral medications. Usually they don't get it to quite where we need to be, but it might make their veterinary visit and their basically perioperative process a little bit more stressful. It might just make them happier. For those of you who have cats, it might be that your veterinarian says, well, give them some gabapentin before coming to the vet, or give your dog some trazodone before coming to the vet. And just in the time that I've practiced, I've seen this kind of wave towards this fear-free stress reduction method of dealing with animals, that we're recognizing that animals do better when they're not stressful. We know that, I'm lucky or unlucky, depending on how you look at it, with anesthesia, that I may just encounter this animal once. Get them through surgery, get them happy out the door, home to the family. But your general practitioner, hopefully, is going to be working with your animal for their whole life. You don't want that to be an antagonistic relationship. So you want your animal to be happy to go to the vet, to enjoy working with that veterinary staff. So sometimes oral medications like gabapentin, trazodone will get us a little bit more of the way there. Now I need to take it the next step further because I need to really poke them. I need to poke them with a catheter. I need to really restrain them. So we're going to have to oftentimes give what we say parenteral, either in the muscle or into the vessel, some extra drugs. Okay? It could be required for stress relief. It could be required for safety. So this is an example of a police dog. We work with multiple police departments, especially in our dentistry and oral surgery department, because these guys get a lot of broken teeth. This guy was actually really nice, but I always say that these animals can be loaded weapons. I mean, you've seen what biting police dogs do as a career. Once you take them away from the handler, me personally, I never fully trust them. Some of them are lovely, lovely animals, and they are amazing and wonderful, as are their handlers. I have nothing but respect, but I don't trust them one iota. So sometimes with these guys, the most extreme case would be a lion, tiger, anything like that. We need to have that pre-medication basically be the anesthetic, and we call that immobilization. We need to give them drugs in the muscle to such a great extent that we need them flat out. We need them to be safely approachable. So on the left, you'll see a camel. On the right, you'll see an eland. This camel was actually at the same place as that giraffe. He needed a dental procedure, so we used a dart. On the right is an eland that actually came in on emergency on a weekend, cold weekend, of course, that he wasn't able to urinate properly. So with both these animals, they got darted. So, you see darting on TV and in movies, and it looks like this just real easy thing. You shoot an animal, often in the neck, and they go down immediately. That's often not the case. You have to find a big muscle mass. Usually these are carbon dioxide powered pistols. The things that you use to inflate bike tires, those little metal cylinders, oftentimes they're powered by that, and you can just kind of put a little bit of pressure in that pistol and then shoot these darts at them. It's not the nicest process, let's say, but if we use the right amount of drugs, we can get them to a place where they're nicely workable, nicely approachable, perfectly safe to approach these animals. But sometimes they have other ideas, and sometimes we need to prepare for the fact that if they swing their head around, we need to put a pool noodle or two on their horns. So we need to get creative in what we do. Okay, so that's pre-medication. Now we're going to the next step, and that's induction. There are a couple steps with that. We need to place an IV catheter, something into the vessel. We need to give that anesthetic to put them completely to sleep, so that we can insert the endotracheal tube. This is an otter that we had. He came from, I believe, a local zoo. And see that nice hole? Let's see if I can get my cursor right in the middle. Right there. That's where we're going to put that endotracheal tube. And I'll show you in a little bit what that looks like a little bit more. Okay, so we have a lot of equipment that we're going to need for that, but we need to be able to work on a tiny, tiny little bird all the way up to something like a giraffe. So we have a wide range of sizes and specialties. For better or for worse, a lot of our equipment will come from the human side of things. So on that upper left corner is a laryngoscope, which is something that we use to see inside the mouth. More often than not, those are going to be specialized for human equipment, so we may need to special order them. We might need to tailor them to what we need to do. On the upper right are going to be intravenous catheters. You can usually get some larger catheters for placement in large animals, but sometimes even the smallest catheter is just too big. And then on the bottom, that's an endotracheal tube. Those come in a huge size, or range of sizes. So if you go under anesthesia, you're probably going to take about a size 7, 7.5. We have, for standard available, size 2, sometimes even smaller than that, all the way up to a 35. So we have a huge, huge range of sizes based on our patients. Okay, so first thing we usually do once they're nicely sedated is we're going to place an intravenous catheter. So this isn't exactly what it looks like, but I thought this was kind of a nice schematic to what we do. So you can see right here is going to be the vessel. This is going to be a little bit different because this is a different technique, but we're putting basically a needle, more or less, down until we hit that vessel and see blood. And what we're going to do is it's going to look a little bit more like this, where that needle is going to be in the vein, and then we don't want that needle to stay in the vein because that could actually hurt it, that can lacerate it. We can put this flexible intravenous catheter over that wire and into the vein. So we have an indwelling catheter and an indwelling port, so all the drugs that we give can go right into the bloodstream, right to the heart, right to the brain to do what they need to do. We've got multiple sites. We've got cephalic veins on the front legs, saphenous veins on the back legs, jugular veins, especially if they're big. Sometimes we have to go a little crazy here. Sometimes we need to go to the ear. We just took care of a seal. We had to go to her flipper. And there are also some venous sinuses that sometimes you can find. So here are a couple examples of that. This is a different eland out in Lake Geneva, where you can see all these vessels in the ear that are really nicely accessible. This is actually a different camel, where you can see this is a branch of the, this was a hind leg, I believe. So this is a branch of the saphenous vein right there. And then in many of our large animals, sorry, it's wrapped, but we'll put a catheter right in the jugular vein. So it depends on the species, depends on the animal, but we generally, almost always, if we can, have a catheter in. Not only to deliver anesthetic agents, but also that we can keep them safe. If their heart stops, if something happens, if their blood pressure is low, we can give agents that are going to go right into the central circulation so that they can move and work really, really fast. So once we get that catheter placed, we can give some anesthetic agents. We're not going to go into those today, but some anesthetic agents that put them into a place where they're so asleep, they're sufficiently anesthetized, that we can insert a breathing tube. So that breathing tube, endotracheal intubation, goes right into the trachea, and it does a few things. It aids in the delivery of gas anesthetics, which we're going to talk about in a little bit. It protects that respiratory system from vomit, any fluids in the mouth, anything like that, because you have your trachea that goes right into the lungs. Only air should be going into those lungs, nothing else. If we have any fluids in the mouth, anything like that, that could go right into the lungs, create a problem. Actually, it can even create arrest. So we don't want that to happen. Not only that, it protects personnel from anesthetic exposure. The gas anesthetics that we use are the same ones that are used to anesthetize humans. So best case, if you get exposure, maybe you'll get a headache. Worst case, you can actually get a reaction to that or fall asleep. Probably not going to happen, but we just want to be safe, and it protects everybody. So we need to oftentimes use that laryngoscope that we saw and a tracheal tube. Sometimes it just doesn't work. Yes, you can technically intubate hedgehogs. It's not very easy. They're prone to kinking, things like that. This little love just needed a mask, and sometimes we'll do that. We'll just put them right into a mask, give them the anesthetic gas, and they'll fall asleep. So we have to get a little creative depending on the species, but this one was just so delightfully rotund that the mask kind of sealed itself around her belly. She's very cute. Okay, so this is in our small domestic species what it looks like to intubate. So this would be a Great Dane, one of the biggest ones that we're going to see. And you can see in her left hand is that little tool, is a different animal, but you'd see this blade that will go into the mouth. A lot of our students at first just want to make it be a flashlight, and yes it is, there's a light at the end, but you can really push down on that tongue, and you can see right here there's something called the epiglottis, which is this little cartilage that is right in front of the glottis, which is the entrance to the trachea. And we see this right here. So here's that laryngoscope right here. Here's a little bit of numbing medicine to numb it. There's that epiglottis right there, and there's the glottis, the hole into the trachea right there. Most of our species are going to be very straightforward intubations. Some are a little trickier, and sometimes we have to do just some random species. There's a porcupine on the left, and you can see, look how big his teeth are. So that's not a very easy intubation just because your visualization is so difficult. that you'll find that the teeth will just kind of be in your frame of view. I find that as my eyes get a little bit older, there are certain species that if their canines are right in front of me, my eyes are having a little bit of difficulty with accommodation. So sometimes we can have a little bit more difficult intubations. And if that's the case, we can go to more advanced techniques. We have bronchoscopes, we can have different kind of scopes that can aid us with that. Sometimes you're presented with species like a sloth that you kind of don't know the best way. So this one was one that we saw for a toe amputation. I've got a friend who is a zoo vet who's worked a lot with sloths. So I texted her and said, okay, what's the best way to intubate it? Thinking that its anatomy would be more like a human, that we'd intubate it on his back, but turns out that's the best way. So we learn as we go sometimes. Okay, so we talked before about one of the reasons why we intubate is to protect that trachea. So right here is our endotracheal tube. This, I wish I could tell you for sure. This is probably about a size 26 endotracheal tube. And this is connected to the anesthesia machine. We'll talk about that machine in a little bit. So this is delivering anesthesia and delivering breath so we can keep her breathing. Now ruminants, cattle being ruminants, are named because they have this really large fermentation chamber, the rumen. The rumen is just one chamber of the stomach that basically serves to ferment. And if you hear about ruminants chewing their cud, it's because they're regurgitating that food, chewing it a little bit more, swallowing it back down so it can ferment. This is a great process. They can basically regurgitate up and down at will. But what happens when you anesthetize these guys? They basically have this giant vat of fluid and hay and just fermented nastiness that once you start relaxing things, that comes up, and we need to protect that airway. So let's see what this looks like. Normally we'll fast them so that this doesn't happen. This was one that was seen on emergency. So you can see we've got towels there to basically create a dam into the drain. So if we hadn't endotracheally intubated that animal, he could have very, very easily aspirated that right into the lungs. It's very, very caustic to the lungs. We don't want that. And our big cattle, and because we're in Wisconsin, we see plenty of them. Lucky for us, they're very placid. They're good. They're just good guys. They're not going to rush getting up. They're pretty okay with just sitting there with that breathing tube while they're recovering. So this was a big bull that we had named Olaf. And Olaf was just kind of happy to sit with his breathing tube for a while. And then once we know that they're really awake, able to control that airway so that we know that if they regurgitate, they can safely protect that airway, then we pull that breathing tube. Okay, so how do we do that in large animals? This is my resident Emmett. This was that camel that I showed you that we darted. And what we can see right here is this is a mouth gag. I think this was actually something made in the machine shop on campus, but you can buy these, where we put it in the mouth, basically screw it so that it'll keep the mouth open, keep that animal from biting down, and then you can put your arm in. Okay, and so Emmett put his arm in. You can feel that epiglottis rather than seeing it. You can actually feel it big enough that you can pull it down, and then with your other hand you can put in that breathing tube. So that's basically how we do all large bovids. Sometimes they're a little bit different. Horses are a little bit different. You can imagine their mouths don't open quite as wide as a cow, widely, and they're also very anatomically designed for running. So as such, the respiratory system is incredibly straight, incredibly straight, that if you keep them kind of in good anatomical alignment, we can do what's called a blind intubation. We know, because we've done it a bunch of times, we know what that endotracheal tube should feel like when it's going in the right place, and as long as you have their neck in proper alignment, it'll slip in. So this was, I believe this was actually a Clydesdale. So you can see how that's meeting a little bit of resistance. So see how we extended that, pulled out the tongue. Somebody's helping here. I think I was being very non-helpful by filming. So, and see how that just slid in? That's how a blind intubation should go. You know, when you have experience, you know that this is exactly what it feels like, and you know how it can just slide in. Okay, some animals are very easy. Some of the easiest being reptiles. This was, I want to say this was a rhinoceros iguana, but you can see that glottis is right there. They're just there staring at you. You can see it right there. So a lot of times if you'll see an image of a reptile, sorry, it doesn't show up quite as well on the big screen, but a lot of times their glottis will be right there looking at you. But sometimes they hide. So sea turtles, and oftentimes turtle tortoise species, can kind of camouflage their glottis a little bit. So this is a sea turtle. I thought I was being joke paged one day when they said the sea turtle was coming in on emergency. We're not North Carolina or anything like that. We're Wisconsin. This came from a nearby museum. I believe it's the Dubuque River Museum, I think it is. She was brought in for an emergency CT. And so we took a look at her mouth. And these guys, it looks like there's nothing there. But guaranteed, as soon as she takes a breath, you'll see this big glottis right there. And then when she's not breathing, it closes right back up again. So they can be a little hard to see. But most of our reptiles are going to be very, very easy. Birds are also pretty darn easy. This is an emu that we had, really large glottis right there. Sometimes our big challenge with these guys, though, is that they're so small. So you cannot have an endotracheal tube small enough for these guys. So we have to get creative. And remember how I talked about that intravenous catheter? We have to use one of those catheters instead to keep a breathing tube in. Okay, so we have them pre-medded, nicely sedate. We have them induced, gave that anesthetic, got them endotracheally intubated. Now how do we maintain anesthesia? If we just walked away now, they'd maybe stay asleep 5-10 minutes, something like that, and they'd start coughing at that tube and waking up, okay? So we need to maintain them oftentimes with inhaled anesthetics, sometimes something a little different. Sometimes we need to keep giving drugs in the vein. In kind of the most fun scenario is fish anesthesia, which we teach the students. To be perfectly honest, our anesthesia department doesn't deal a lot with fish anesthesia. Sometimes special species will do it if they have a koi or something like that. But if you go to a place like SeaWorld, of course, Disney, places like that, they'll do a lot more fish anesthesia. But what you can actually do is put that anesthetic in the water, and then you're more or less putting it over the gills. And so you can anesthetize them with that anesthetic in the water. Something we don't do very often, but the students love it when we teach this lab. Okay, so for those of you who enjoy chemistry, this is kind of the history of our inhaled anesthetics. So nitrous oxide is laughing gas. That's still in use today, but one of the earliest ones is just going to be ether. Ether and chloroform, of course, popularized by just putting it over a rag and over somebody's face. But there's been this wonderful evolution of these different inhaled anesthetics, but the use of inhalational anesthetics has been around for many, many, many years. But now we've got our monitored anesthetics right here. So isoflurane, desflurane, and sevoflurane are going to be the three most commonly used, and they all share the fluorine part of it. So they're delivered to us, so if we were to buy a bottle of these, they're delivered to us in liquid form. Okay? We need a way to vaporize them, because if we wanted to, like the movies, we could put some on a rag and put it over somebody's face and they'd go to sleep. That's not safe. We need to deliver it in a precise way, and so we use the anesthetic machine, okay? So this is just one example of many, many anesthesia machines, and what you'll see is right here is a piece of equipment called a vaporizer. So you pour that liquid anesthetic into that vaporizer, and then it's got a precision splicing technique that something like oxygen will go through that vaporizer, pick up just a certain amount of that anesthetic to be delivered to the patient. So we've got a ventilator here, we've got oxygen, there would be hoses coming out in a bag to make them breathe. And this is what it looks like a little bit more practically. I told you that we have that ZoomEd Outreach. This is their new anesthesia machine that's nicely portable, that they can basically put it in a suitcase. Okay? And this is kind of what it looks like in our induction area. We have just basically littered with anesthetic machines. We're just kind of sitting there chatting, and there's one off to the side. Our ORs will have anesthesia machines that look a little bit more like this. And then here it is in use with a large animal. So this is a horse, of course. And this is just a very, very large anesthesia machine. They're all schematically pretty much the exact same thing, and they serve pretty much the same darn purpose. They're just going to look a little bit different, be different sizes. We can do it on anything. So I told you that reptiles are very, very easy to intubate. You can see that that glottis is right there with a very well secured endotracheal tube. And you can see he's just hooked up to an anesthetic machine. So we had him on the anesthesia machine to keep him nice and safely asleep. This was a snake that came in that was so large we had to use 3 tables to make sure he was properly extended. He ate a dog bed. Ate a dog bed. You could probably imagine why he would want to eat a dog bed. He probably thought the dog was in the bed. But came out very nicely. Everything went great. Okay, so not only do we need to keep them asleep, we need to keep them safely asleep. So we continuously monitor these guys. We'll monitor their heart rate and rhythm. We'll do it with a pulse oximeter, an ECG. We'll monitor their respiratory rate and their respiratory depth. We'll do it with CO2, with measuring their carbon dioxide. We'll measure their temperature. We'll measure their blood pressure. We'll measure their depth. Sometimes this can be really, really straightforward. So, whoopsies. Sometimes this cannot be straightforward. This is a veterinary nurse who has since gone back to Oregon, but Caitlin, and you can just see, what is going on here? So sometimes we'll have these really intense cases, and we're running blood, and we're running, multiple fluids and multiple drugs, and they can be very, very stressful. This can be very boring. This can be very great. A lot of people will say with anesthesia, it's hours of boredom, moments of terror. Okay, it does require a fairly intimate knowledge of physiology, and basically just knowing when something's wrong. So if you're sitting a case in the OR, this is what you're going to be staring at. So what we have up here is ECG, so continuously monitoring ECG. We have pulse oximetry, which is the oxygenation of the blood. We have carbon dioxide, which is measuring how much carbon dioxide the body's putting out, as well as how they're breathing. And so you're just sitting there mind-numbingly looking at this, but can you guys see what's wrong? See that little skip beat right there? Okay, it's called a second-degree AV block. It's common, it's not a big deal, but you need to know that. And even though you might just be staring at that screen for hours and hours on end, you need to be on your toes to not only identify that, but then to identify the fact that, oh, it's okay, it's fine, they do that. We see it all the time. Okay, now here's one. So this was one where when COVID first happened, actually not even first happened, this was more towards the summer, I think, we were starting to, our students were trying to do distance learning. So I thought, well, this is a great case. We had a case that they were in the chest, they were going to ligate this abnormal vessel. It was going to be great. And normally what happens then, the blood pressure goes up, heart rate goes down a little bit. This is going to be great. This is going to be terrific learning for the students. So I decided to just sit in the OR and film it when they were ligating it, okay? So remember this ECG, but right here we've got invasive blood pressure. So what this is a catheter in an artery measuring blood pressure and row. And not only that, but you've got your pulse, and that's going away. And this is speeding up. And not only that, he's now generating less carbon dioxide. So you'll see that we flush, that something's wrong. But this is kind of the oh no kind of moment, probably not necessarily oh no, probably other less nice words, where if I had the sound on, you'd hear my veterinary nurse saying, that's weird, and me finally asking the surgeon, what's going on? Is the heart beating? Because sometimes things can go very, very wrong. So that's that hours of boredom with moments of sheer terror. This was a little bit of a sheer terror moment. Dog did fine, everything went great. But this is what we do, is this continuous monitoring. I turned off the sound. Here, let me turn this back on. Let's see if it works. Sometimes it's just something simple. You can hear so much background noise. Just something over the heart, just knowing the heart's beating. Sometimes that's all we ask for. More often than not, we're more complex monitoring. All right, come on. There we go. There we go. Okay, and then here we have, that was our friend the redfoot tortoise from earlier, and a lot of times we'll just have multiple monitors on, because not only are we monitoring multiple parameters, we want those parameters to come from multiple sources to know that they're safe, okay? That other one was that emu we saw as glottis a little bit ago. A fun thing about emu, that when I teach my students, what do you do when you're encountering a species that you haven't worked with? Google it. So emu had this really abnormal part to their trachea that they basically have, for vocalization, this sac that comes off their trachea, that if you give them a breath, you'll just kind of expand the neck. So you can see his neck is all wrapped up so that doesn't expand. And this little guy got a wing amputation. So you can see how sad their little wings are. That's why they're flightless. But this was my dream of anesthetizing a dinosaur. He kind of had velociraptor feet. But you can see that we've got all these different monitors on. We continuously monitor them. Okay, so now we're on to recovery. So that's the part where we've got to wake them back up, make them happy, healthy again. So you really need to balance speed versus smooth versus safety. And we oftentimes don't get all three. Okay, so a pig, something young like this, you can see that we're still in the OR. So that one was a fast recovery. But fortunately, it was a pretty smooth recovery. Sometimes horses, we want it to be smooth, and that's not always fast. But at the same time, we don't want them to lay there too long because they're just big animals that aren't meant to be in recumbency for too long. And then of course, with our zoo animals, we really need to make sure that personnel is safe because human safety is going to be number one. So this is just kind of 4 different pictures of how animals can wake up. So this is a corgi that woke up in dentistry, and this is not uncommon for a young dog in dentistry. You can see he kind of has no control of his tongue and just kind of crazy eyes. You can see the corners of his lips are pulling back. If I had a video, you could see that he was actively vocalizing. So what happens is when these animals are waking up from anesthesia, some are worse than others. They're sometimes in that in-between stage. They're somewhere in between general anesthesia and just kind of sleeping nicely and wide awake. And sometimes they make this little way period in a spot that's in between and not in a good way. And he was doing that. So sometimes we need to give them a little bit more sedation, just like we do on the front end. We talk about stress of patients. Sometimes cats in particular can be really stressed. This was one that woke up pretty nicely, but when we came to check on him, you can see he's panting, his tongue's out a little bit, he's salivating, his pupils are dilated. So not only is anesthetic recovery just sleeping to waking up, we keep them in our recovery area and we monitor them for usually about 2 hours at least to make sure that they're not stressed, that they're not hot, that they're not cold, that things aren't going wrong. Something that we like to see with cats, though, is just zonked out. He was just sleepy. That's okay. We are generally okay with them just sleeping it off as long as they're not getting cold, which sometimes they do. And so what we have is this bear hugger, which this is basically just a glorified hair dryer that blows onto them. And then this guy shows that sometimes they just wake up cute. Like sometimes they wake up and they're just happy and life is great. Horses are some of our most harried recoveries. Horses are prey species. They don't want to be laying down. That's a very, very vulnerable stage. We certainly have little prey species like rabbits, and that's not that big of a deal. These are big prey species that kind of want to kill themselves and those around them, not intentionally, of course. So sometimes what we'll do is we'll put ropes on them to help control them up. We put basically tape over their horseshoes so that they don't injure themselves or our padding or our flooring. And what horses get, let's see if this video will work. Here we go. See how his eyes doing that? Back and forth, back and forth, back and forth. It's a very horsey thing to do when they're waking up. Not all species do it. Rabbits sometimes do, birds sometimes do. Horses get this called, let me start that again, called nystagmus, where that eye just kind of goes back and forth, back and forth. That's what happens as they're coming out from anesthesia. So if you can, this can happen in humans sometimes when they're drunk or if they have middle ear problems. They're dizzy. The room is spinning on that guy. I mean, think of your worst drinking night where you lay down and the room is spinning. That's what's happening to this guy right now. He's over 1,000 pounds. He is not in a fit state to stand up, and he is not safe to be around. So a lot of times we'll sedate them very heavily, just see if they'll sleep it off. Sometimes we have to sit on their head. They need fairly decent strength to be able to pick their head up. And so sometimes we can just kind of hold them down for a little bit longer. They need to be able to pick their head up and pick their neck up to get their whole body up. So sometimes we'll just hold them down until they're good and ready, and then we'll assist them with ropes. But you could see this guy. I mean, just look at his body language. He doesn't really have great coordination of his legs. His tongue's still out. So we'll help him up with ropes. Okay. And then we have our giraffe friend. So if we have an immobilization, we can use ultrapotent opioids. The most popular in the news would be carfentanil, which is no longer on the market, but really, really, really potent, something similar to morphine that will anesthetize them. But the good thing is that it's really easy to reverse. So this guy went from anesthetized. You can see his breathing tubes right there. This is hooked up so we can give him breaths. So he went from anesthetized, we need to breathe for him. And this was about 5 minutes after giving reversals. So we pulled the tube, basically ran out this way. And so this is one where you really want that speed in recovery, but ideally you want it to be smooth as well, of course. You want him to get up. And so, again, just about 5 minutes after giving that reversal, and us running, probably about 2 minutes after us running out. And stood up beautifully. This was a perfect, perfect giraffe recovery. There was cheering in the room. Okay, so let's transition from anesthesia to One Health. I promised you One Health and many species. So this was one of my proudest moments. It was the day after I got my COVID shot, so I was not feeling great. But got called on emergency brain surgery on a bonobo at the Milwaukee Zoo. So bonobos are also known as pygmy chimpanzees, share a lot of DNA with humans. And this guy was 5 years old, I believe, and looked pretty equivalent to about a 3-year-old. He had a mass in his brain, which turned out to be an abscess, and they had a human neurosurgeon come in. So it was the veterinary team from Milwaukee Zoo. It was myself and my resident at the time coming in from the vet school, and this human neurologist and his neurosurgery team, all coming together to work on this bonobo. And it was one of the most rewarding procedures of my entire career. And it really highlighted the importance of this One Health, okay? So One Health is important. You guys are often, many of you are UW alumni, many of you are scientists, you know about this. I know this very narrow band of anesthesia within veterinary medicine, but you guys in the room, on Zoom, you are so important to this that not only is it veterinary medicine, it's human medicine, it's plants, it's the environment, it's everything. This all comes together. Closer to quite literally my home is my husband. My husband's a human anesthesiologist, and so together we are UW Anesthesia. Not really, of course. Okay, so UW Anesthesia, we've got UW Veterinary Care, as I talked about. We have 7 faculty and 4 residents. We have UW Health Anesthesia, and just at the main campus here, not including kind of some of their offshoots, you have 80 faculty and 50 residents, roughly 10 times what we have. They share a 3-year residency program, and a residency program that has certainly lots of differences, but a lot of similarities. So what we started was the University of Wisconsin Veterinary Care Senior Resident Rotation Program. Okay, so the human, we call them human residents. You'll catch me doing it because I just can't break myself of the habit. The MD/DO residents in their last year of their anesthesia residency will take a 1-week rotation to rotate through with us. It is a wonderful program for the 2 of us. This was a resident that came through. She just wanted to hold the hedgehog. She was so happy. They're so happy. One of the residents described it to me that this was the first time in years, probably since before undergrad, that he could learn for the sake of learning. They've had these high stakes learning, put on the spot, being asked questions, having to answer questions, having to get it right for so long that they could just learn for the sake of learn. They're in their final year of anesthesia. They're just about to become specialists in their field, and now they get to branch off and see, wait, there's more to anesthesia here, and this is what we do. And it is such a rewarding program. This resident right here is one of the human residents. So see, I do it all the time. And then this is Nick. He's one of our veterinary residents. So I was on for the day. We needed to put an epidural catheter in a calf. You can see it's a little calf right there out in the large animal hospital. I've placed plenty. This was going to be Nick's first. And the human side of anesthesia places a lot more epidural catheters than we do. So this human resident had rotated through with Northwestern, with OB, all sorts of epidural catheters. Honestly, probably far more than I've ever placed. So I said, okay, why don't you guys work together? So it was such a proud mama moment where you have this human anesthesia resident teaching my resident and working together. Nick has worked with a bunch of cattle. He's worked with a bunch of epidural catheters. It's just this really wonderful give and take. And actually today over email, I was working on getting the paperwork together for my residents to rotate through with them. It's wonderful. So this program was featured in our OnCall Magazine, which is basically our magazine that features the School of Veterinary Medicine. So Chris Darling is one of the anesthesiologists at the Human Hospital, and he's the program director. And you can read it, of course, I don't need to read to you, but it's really, really good for their recruitment. These residents love it. They tell each other stories about it. They share pictures of it. They're proud. They're very happy. And then it's been a great recruiting tool for them to bring in high-quality residents into their program. We're the first program to do that. I've spoken with one of my anesthesia colleagues in Minnesota. They're going to start that program soon. So this is a program that's growing. And it goes both ways. So this is my husband again right here. This is their sim center. So we've created the opioid exposure experience for 4th-year veterinary students. So I teach a 4th-year elective for the vet students that they learn exotic animal anesthesia, and part of that, like the giraffe, is using ultra-potent opioids. So what happens if you or your colleague are exposed to those opioids and you get an opioid exposure that can cause respiratory arrest? So Chris and the Sim Center go through, teach them what to do if they're encountering somebody with an opioid exposure in the field. Their residents volunteer to help show how to intubate humans, things like that. Not only that, but when their residents come through, every time I learn something new from their residents, my residents learn from them. I remember one time I looked out in the hall, and there was one of their residents, and he was just surrounded by vet students. They always are good for good stories. They always want to hear our stories. It's this wonderful, wonderful give and take. So it really kind of just highlights the One Health, and this is just one small band of One Health. There's so much more that can be done with this. For a long-term goal for me, I want these residents to be friends. They're kind of growing up together in the same program. UW is in partnership with several of the other Midwest programs to have the Midwest Anesthesia Resident Conference, which is always human anesthesia, and residents presenting abstracts, cases, things like that. And at least 2, now I think 3 of my residents are going to present at that human anesthesia conference. So it's this just wonderful, wonderful program, and I'm so proud of it. And I'm so proud that we can pilot that here. The most recent resident that came through was there when we had an emergency seal come through. And I gave this guy the world. We thought he had to leave, that he was done at the end of the day. He texted, he said, I'm just gonna move my car and come right back. He was so proud, he was so happy. What we do is just so valuable. What they do is so valuable, and we can work together. Okay, so I finished a little soon. I get carried away and I start to talk fast because I get very excited. But I would absolutely love to hear your questions. Yes?
I wonder if you do any genetic testing for adverse effects to anesthesia.
That's a great question. Are you genetics?
No, I'm an electrical engineer.
Oh. Oh, you probably would have loved our machines then. Man, you got to come over and look at our anesthesia machines. So the question is, what kind of genetic testing do you do for adverse events? That's a great question, and it's one that there's some work done here, not necessarily for anesthesia, but there's definitely work done. Oh, I want to say it's Washington State has a whole lab for that. So the most classic one would be the MDR mutation that's seen in some of the herding breeds, border collies, Aussies, things like that, that they do have a known sensitivity to some of the drugs that we have. And so a lot of them will come to us with a known carrier or a known MDR mutation that we'll know that, okay, maybe we should go a little light on that drug or avoid that drug in that patient. Taking it a step further with something that would be very rare would be malignant hyperthermia. It's a genetic condition that's very well known and very well hashed out in humans. But there are similar syndromes that are known in veterinary species, and pigs would be one example. There are certain strains of greyhounds. There was apparently once a strain of labs in the Madison area that had it, where they would show kind of unique sensitivity to certain drugs. Quarter horses. Quarter horses are this really, really interesting breed of horse in that they have what's known as the impressive trait. I would encourage you to Google it because it's fascinating. That once upon a time there's this really impressive quarter horse named Impressive, and he got really well bred. And all descendants, many descendants of that horse will have either a carrier state or homozygote for this HYPP, hyperkalemic periodic paralysis, something that can be triggered under anesthesia, and their potassium will go really high. So yes, there are definitely known genetic disorders. What we more often get is people saying, well, my breed is sensitive to this. And that's common, and what that more so is that, breeds have different personalities, they respond to drugs a little bit differently, but the known genetic predispositions are absolutely out there. Here at UW, there's a lab upstairs that's looks at genetics quite closely and has looked at orthopedic injuries, things like that. But as far as the anesthetic mutations, I believe it's WashU that does a lot more. Yes?
If dogs and horses are this complicated, how do you deal with, the wombat or these things that you don't see very often? And
so the question is, if dogs and horses are complicating, how do you deal with kind of the rare case that comes in? I told you about the seal that just came in. I mean, I'm fortunate that I have this huge zoo interest, and so I do have a bit more background. Most of my colleagues do. That's the point of residency. That's why you have residency support. but are you going to be presented with that species? So most of us will kind of talk about, well, yeah, I anesthetized this. This was pretty similar, but I didn't anesthetize this thing. So what got me started in thinking about this a little bit more, two things. We had this giraffe that was going to happen, and giraffe is a bucket list anesthesia, kind of high mortality, obviously an amazing species. They present a whole slew of risks. So Jeff Zuba is a UW alumni, actually. He was at San Diego Safari Park for many, many years and recently retired. So we were fortunate enough to have multiple Zoom conversations with him. He shared his knowledge with us. He came out here, helped us anesthetize that giraffe. We've subsequently done that one again. But so you kind of get this tribal knowledge that you share. It doesn't mean that there's not going to be some random emergency that comes walking through your door and you have to maintain composure on the outside, and inside you're, I don't know what to do. So that's when we kind of need to go to similar species. But getting back to the giraffe, what got me thinking is there are several anesthesiologists across the country that, a lot of us have our friends, we'll text each other, but it's really powerful to share our knowledge. So I, with my colleague in Minnesota, created the Midwest Zoo Anesthesia Consortium. So MZAC. So we actually just had a meeting this week where we presented the seal that we just saw, and Minnesota presented the gray seal that they saw, and we kind of just shared that knowledge. So we can have the ability to go beyond what's published in the books, because many things aren't published very well, just to share that anecdotal knowledge, because a lot of us have anecdotal knowledge, and that's kind of all we have to go by. So the more we can share that, the more powerful that is. But honestly, sometimes we're just taking a leap. Most species we know what we're doing now. Yes?
So I'm interested in staring at the heart rate and blood, et cetera. So I try to track AI in health, and they do have programs
Yes.
that in real time can tell you if something's going on. So have you looked into those and implemented? Or?
So there is a lot more AI in the human field because it's one species, right? They've even looked at kind of AI-based titration of anesthesia, that they can look at some of those cardiovascular parameters and give a little bit more anesthetic based on that. That I feel like there's always, radiologists will say this, anesthesiologists will say this, that we could be replaced by a machine. But there's also just kind of that human touch. A great example of that would be some of our monitors. Most of our monitors in the OR are going to be human-based monitors. There's one, I can tell you exactly which one it is, that every time says CVA, so it thinks that there's something wrong with the cardiovascular system. But no, it does. It might be for a human, but I can tell you that the ECG from a Chihuahua and from a cat is going to look different from a Great Dane or from a llama or something like that. I think we deal with not only so many species, but within those species, so many breeds, that I think it'd be really difficult to do. I think if you did horses, horses are probably the best example of not a huge range. I mean, certainly you can have a pony versus a Clydesdale, but there are certain, cats would probably actually be the even better one, where there's not a huge range within the species. Dog breeds, we just have so many that even breed to breed, there's going to be so many differences that I think that would be a big leap for AI. Not with a beyond the realm of possibility, but I think to have that human touch and that human experience, it's just like, that's what they do, it's fine.
You need good training sets.
Yes.
And you're generating.
Yes. But I agree. I think that's absolutely fascinating. Ultrasounding is another thing where AI, you can kind of give you real time, well, this is this structure, this is this structure. I think there's a huge future in that for sure.
Last year there was a news story of a human who received a pig heart. I'm anticipating that in the coming 5-10 years that kind of thing is going to become more commonplace, perhaps standard. Are people anticipating what anesthesia will need to do if you have a human with livestock parts?
That's why we have to advocate for One Health. We'll work together. Get the cardiovascular system of pig and human. Now, pigs are interesting. They're very humanish. They don't seem like it, but anesthetically, just even placing a catheter,
I've been
intubating,
called
they're
a
very
pig very
human-like.
often, so I can see where that would be. Yeah.
To be perfectly honest, every time I place a catheter in a pig, I make comments of, oh God, it's bruising. It's just so gross. I'll take fur any day.
So the other question was that beautiful long yellow snake that ate
Mm-hmm.
the dog bed. How did you get the dog bed out?
That's a fantastic question. So we see a lot of foreign bodies. So foreign body would be if an animal eats something. We see it quite often. There was one today even in a dog. That's just kind of what they do. We don't see a ton in snakes. So what you can do is you can go basically non-invasively. You can put a scope down the esophagus. But what they found was that it was just too big to pull out. So they had to, and this is something that we commonly do in small animals too, that they'll try to go in with the scope if the foreign material is in the stomach, and they can pull it out that way. But if that doesn't work, you have to go to surgery. So that one, we obviously kept it anesthetized. Fortunately, I don't have to do surgery. But our special species team actually did a gastrotomy. Actually went into the stomach and pulled it out. I'd have to dig. I have a lovely video of them pulling the dog bed out. And we were actually kind of holding the snake down because you don't want to make too big of an incision as they pulled the dog bed out. Very successfully. He did great.
Wow.
Yeah.
And about how long was the incision on that?
Oh, not very long.
Okay.
Not that long-ish? Not that long.
Is
Our
that-
surgeons do amazing things.
Wow.
It's another
Other-
reason I went into anesthesia. I didn't like surgery.
Other questions? If not, thank you very much. This is
I
great.
very much appreciate this. Thank you. And feel free to email me anytime with any questions.